Here we have Ken Davis, who's the president and CEO of Mount Sinai in New York. We've got Jonathan Perlin, who is the president of Clinical Services and the chief medical officer of HCA Healthcare, which is the largest for-profit chain, correct? And is also a veteran of the VA, and we'll talk about that as well. And Diane Holder is Holder, right? Yes, is the president and CEO of the University of Pittsburgh Medical Center. So I actually wanted to just start out, when we think of a hospital, most of us grew up thinking of a hospital as a building. You know, maybe a red brick building, maybe two buildings, but it was a building. It was a place you went, and that's what it was. Then somewhere along the line, no one calls themselves a hospital anymore. They're all a health system. So just before we talk about the future, I wanted to talk really briefly about the past and present. I want each of them to just very briefly, not a presentation to the board, but just very briefly say, this is what we were 10 years ago when we were more hospital-ish, and this is what we are now with tentacles. That I don't mean it as a nasty word, tentacles, but tentacles into the community. Tentacles isn't the right word, but you're in the community as well as the building. And then that'll be a good starting point before we talk about what's next. Diane.
So UPMC is an academic medical center, and if you looked at our history, it would be very similar, I think, to what you're seeing with large systems around the country, where, you know, hospitals were pretty fragmented, disconnection between inpatient and outpatient care. But about 20 years ago, actually, we started consolidating and building that full continuum. So now we have maybe 40 hospitals, but the vast majority of care takes place in our home care, our hundreds of outpatient offices, our work with people in crisis intervention centers where there's 24/7 behavioral health, community workers who are in, you know, non-traditional settings where you can meet people where they need the help. So it's a very different kind of world now. And I think when you look forward, what will be additionally true is that we'll see a lot of the work we're doing now in digital and that connectivity for people and that ability to use your iPhone for your visits more frequently. I think that's really heavily where we're going.
Why don't you talk about, tell a little bit about the company and all, but then pick sort of one sort of typical hospital and how it's changed.
Well, thanks. Good morning, everybody. Delight to be here and thank the Aspen Institute and Spotlight Health for the opportunity. And, you know, I think your question is a terrific question. I had the privilege 2 years ago of being the chair of the American Hospital Association. We embarked on a program called Redefining the H. You know, that blue sign with the white H gives comfort to people, but the concept of a hospital really is evolving from the bricks and mortar of entry and exit to a concept that really spans from the most acute setting when patients need that to really into the home and workplace. That is healthcare of the future. As for my own organization, we have the privilege of caring for patients in about 34 million encounters every year. I joined after having come, as you alluded to, from the VA integrated delivery system, and it really was a hospital company. I think it's notable that HCA changed its name this past year to HCA Healthcare, really representing the fact that we have 2,000 sites of care, the majority of which are practice sites, et cetera, but a large digital presence, and admittedly, there are about 178 hospitals across the United States, 21 states, and in London. But you know, we have to get beyond thinking about the bricks and mortar, because what's really exciting is the data mashup that comes from consumer devices, patient-reported outcomes, as well as the formal healthcare setting, all come together to create a data ecosystem. And what's really exciting about that isn't the data ecosystem, but that we really have the opportunity for a new health ecosystem that can embrace the continuity between health and wellness, as well as acute care and sickness when that's necessary. I look forward to a conversation about that.
Candace has the only hospital of your three that I've actually reported in a clinical setting. I've been there, I've talked to, not recently, but staff and patients, so the one I have the most familiar. And you dealt with my grandmother too, but we won't talk about that.
So there are really two parts to your question. The first part is, what's the hospital? How's the hospital different? But we also have to talk about how the system is different, because that's been a huge change in healthcare. Well, the hospital now has lots more ICU beds because sicker people come to the hospital. The healthier people stay out of the hospital. The hospital has less psychiatric beds, not because we want to shrink the psychiatric footprint, but because more psychiatric care is outpatient now. It's partial hospital programs. There's less rehab in the hospital now because that can be done in other places. We need the hospital really to take care of sicker people. And the complexity of the cases are much harder. The operations take longer because there's a lot of ambulatory surgery centers where the simpler surgeries happen. But more transformative really is what's happening to the system at a level that you can see and feel, and also at a macro level. 10 years ago, we were Mount Sinai Hospital in Manhattan and one little hospital in Queens. Today, we're 8 hospitals. We were about 30 ambulatory centers. Today, we're 300 ambulatory centers. We were $2 billion in revenues. Now we're $8 billion in revenues. We had about 12,000 employees. Now we have 38,000 employees. We've changed from a fee-for-service model to a risk model, where we are accepting risk in all our contracts. And perhaps most indicative of where the field is going is we now have spent $100 million a year in care coordination, in things we never get reimbursement for. We would have never done that 10 years ago. And that's a statement of where healthcare is going, integrated into the communities where we can keep people well. And perhaps the most distinguishing feature that we would have never even thought about 10 years ago, but is critical to us now, is a program called Hospital at Home, where we keep people who have most internal medical problems and modest case mix index or modest severity of illness at home, and they get the same care as they would have gotten in the hospital, but they have better outcomes and they are more satisfied.
And that was something that you hear a lot about pilots and demonstrations in DC, and that's one that has proven its worth and has been sort of institutionalized, and it's in the community. That's the wrong word. It's been made part of the ongoing healthcare system. It works. It's being used in a number of cities now, and it's being paid for, which is always a problem.
Right.
When we talked before, the idea of like talking about the future of healthcare is a little bit broad. So I asked them each to think about one thing that they're beginning to do, or sort of in the early stages of that they're excited about, that their institution's doing, that is exciting. And then I also want to talk about the barriers, because everybody in healthcare has great ideas. They work out. We have barriers in spreading good ideas. We have barriers in getting paid for good ideas. So then just start with something that Pittsburgh's doing that is in the newish stage, or building out that was small and you're making it system-wide, that you're just jazzed about.
Well, I think one of the things that really differentiates us, in addition to the cutting-edge science that we've been doing for a long time and the other kinds of innovative care, but one of the things that we've done that has grown from a relatively small piece of our business to a very large component of how we are thinking about healthcare is that we grew a very robust set of insurance companies. And so in addition to building out all the horizontal continuum and making sure you have care coordination across hospitals and doctors and all the other pieces, we started insurance companies about 20 years ago and have been the fastest growing in our region. We're now the largest in our region. And that now, if you look at all of UPMC, so at a top line revenue, we're about $16 billion total. And half of that is coming in from the insurance side and half from the clinical delivery side. And part of why that's so important, it's not because we want to be in the insurance business to be in insurance. What we really cared about is trying to figure out how do you align incentives, because one of the things we think is really quite broken in healthcare is that there really isn't the same kind of incentive alignment with our clinical delivery side necessarily, and what people are looking for and what's being paid for. And so our ability to have a laboratory where we really can take the best of the best practices in academia, understand how you transform clinical trials into everyday work, and then think about how do you have payment leverage to create things you don't have to ask permission to try, and if they work, try to scale them. And so there's been just a whole lot of different opportunities for us to improve maternity care, prenatal care, looking at how we work with people with severe and complex chronic conditions. How do we keep them at home? And how do we get upstream both in terms of the illness and the complications, but also how do you get upstream with the dollars? Because the way we're going nationally, we're already broke the bank and we're going to break it further, right? So we know it's not sustainable. So we're looking for the things that scale, that improve both quality as well as affordability.
Jonathan.
Thanks. Imagine if you could look into the collective memory of everything that happened in healthcare across all hospitals, all physician practices, the personal experience, our Fitbits and everything else, and know what works or what doesn't work. Well, we see this opportunity after meaningful use, the investment of billions of dollars in computerizing healthcare as an opportunity to learn, to make improvement at speed and at scale. And this is something that I've come to after years of thinking about it. I had the privilege of running the VA system, and we computerized early on. In 2005, I got a call to the White House, answer, of course, I'll come, and had a very special guest there, Bill Gates. And the president asked that we demonstrate the electronic health record. And we showed him that whether a veteran after Katrina relocated to Washington State or Washington, D.C., his records or her records could be followed. And he looked and sort of nodded his head and said, that's nice, but why aren't you learning? Now, at the time, no one was doing that, and you could go down to the office supply store and buy a multi-terabyte hard drive, so it was all the data you possibly had. Fast forward a few years, I think on the basis of computerizing VA, President Obama asked if I'd lead the Health IT Standards Committee on the harmonization of data around healthcare. And had the opportunity to do that and came back to my own home institution, and this question was haunting me. And I didn't understand the question at the time, but it was really the question of big data and data science. Once you created all these data, how did you get past the transaction of healthcare where the data are linear? Just, you order a test is completed, the doctor or nurse practitioner reports the results back to the patient, to creating a virtuous circle, a learning health system, an idea that the Institute of Medicine in 2007, now the National Academy of Medicine, have really promulgated, where the inevitable data byproduct of every healthcare encounter became fuel for learning and improvement. Let me give you an example. So we're working on drug-resistant infections in hospitals. And this is a big problem in America. About 1 out of every 20 patients leaves, if they're fortunate to leave a hospital with something they didn't come in with, a hospital-acquired infection. That's about 2.1 million patients a year. About 80,000 patients pay the ultimate price. They die, and that 80,000 is more than the aggregate carnage of breast cancer plus car accidents plus HIV combined. About a quarter of all those infections are from forms of staph, substantially staph, multi-drug resistant staph, or MRSA. And we had used some techniques that were done in the Scandinavian countries to try to reduce the rates, and we had got them down fourfold, and it was pretty good. And I was presenting this data at the Institute of Medicine, and some colleagues from Harvard and the CDC said, well, that's nice. How do you know it's best? Could you actually use your system as a learning system? Could you use the emerging standardization of data to really run at scale a trial that would compare 2 other strategies in equipoise? That is to say, no one knew among these 3 contenders which was really best. So the base case was taking patients who had had multiple healthcare encounters and swabbing their nose for checking for MRSA. If it was positive, doing something that's not so friendly, putting them in isolation, barrier isolation. And that's what had driven the rates of MRSA down fourfold to really best in class. But there was another approach which did the same thing, but then an antiseptic sponge bath and antibiotic nose drop. Or third, skip all the screening, just do the sponge bath and nose drop. Well, over the course of 18 months across 43 hospitals, here was the answer. The headline in the New England Journal was that on top of all known best practices, that third strategy, universal decolonization, reduced potentially life-threatening infections by nearly half, 44%. But I think it missed the other headline. It didn't take one hospital 64 years. It took 43 hospitals 18 months to get to that answer. And later I'll tell you about some of the follow-on studies that are getting into the literally nearly 1 million patients. But that study involved 75,000 patients. And while it changed the approach worldwide to how we prevent infections in ICU, what excites me and scares me at the same time is that I'm glad we got to that answer in 18 months. But you know what? I wish, using the variation that occurs in healthcare, we could have reached into that collective memory and had that answer in 18 minutes. So what excites me, Joanne, about the future is tapping into this big data asset, the natural byproduct of all of healthcare, reaching into that collective memory to learn, improve at speed and at scale, because I think we can save lives, improve safety, improve compassion, effectiveness, and certainly in terms of the sustainability of healthcare, the efficiency.
So my question, before we go to Ken, the first thing that I hear Because I know how hard it is to spread good ideas in healthcare, and I know how long it takes to adopt a proven good, this is New England Journal of Medicine, and big numbers, right? Are most hospitals doing this?
Well, I'm so glad you asked that question. We didn't rehearse this. But she's referring to the work by Baylis and Bornstein that showed this 17-year translational gap. It didn't take 17 years. It took 2 quarters. We didn't get the 44%.
No, the rest of the country. Is the rest
We didn't get the 44, we got 42%. It is now in the CDC Compendium of Best Practice, the Infectious Disease Society of America, Society of Hospital Epidemiology of America, Association of Professionals in Infection Control, World Health Organization, have all embraced this as the best practice, and this is the dominant standard. There are a couple of other things that are in trial. I'll talk about that later, but it really has gone into practice.
So it's the standard in practice, not just a standard in a bunch of guidebooks that people may or may not read.
It has substantially become the standard in practice, and remarkably so. I think the magic, though, in our own institution is people felt a sense of ownership, having created the data, feeling compelled to really use it. And because the issue you address is that we have this horrible translational gap where we don't apply the knowledge that we have. I'm talking about creating the knowledge, but if you don't put the knowledge into practice, it's a problem. We did a study for the March of Dimes where, against the backdrop of all of millennia, in the last 35 years, we had shortened gestational age, the time mothers carry babies to term, by almost 2 weeks, 10 days. And the question was, are the outcomes still the same at 37, 38, or 39 weeks? And it turns out across 90 hospitals, 27 hospitals, 90 days, 18,000 deliveries, the risk for something bad using going to the newborn intensive care as a proxy was 4-fold greater at 37 than 39 weeks, twice as great at 38 versus 39 weeks. And so it was really clear, all other things being equal, when mom or baby are in distress, then you can go to C-section or early delivery. But when it's elective, don't do it. So to your point, we ran a head-to-head trial of 3 approaches to changing behavior. First was education. Didn't work. The second was have the physicians do a mea culpa afterwards. Didn't work. The third was have the medical staff adopt a policy called the hard stop where you'd be sanctioned if you did it. Did work, and that became the standard. And it's a shame that we have to go to that, but this issue of taking the evidence and really getting traction on putting it into practice is tough.
Right. Ken, the growth of your system. And are all your hospitals still in urban areas?
Yes.
You're all, okay.
Yes. So you asked what worries me the most. Right.
No, I asked
What's
you
the
what you're
biggest-
excited
what's the
about.
biggest-
What are you excited? First, I'm going to let you be happy, and then we'll get sad.
Well, for a system like ours, in the neighborhoods that we're in, what makes me happy, I can't even remember. In my job, the question is, what do I worry about the most? And what I worry about the most starts at a larger level, which is the U.S. can't afford its health care. Whether it's employers, employees, whether it's the insurance companies, whether it's the government, whether it's state or federal, everybody knows that they can't, that we're on a course that ends in catastrophe economically. So that only means that our top line revenues have to keep coming down. They will never be growing as fast as the expenses that we have in our system. So the question becomes, what are we doing that's innovative, that allows us to maintain our core values, which is to take care of everybody who comes to our door. And in some very poor communities, that means on every Medicaid patient, we lose 33 cents on the dollar. So how do we maintain our values, be able to stay out of bankruptcy, do all the things we want to do, and still be an honor roll hospital and a leader in education and in research and innovation, which we are? That's a tremendous challenge. So we made the decision in the market that we're in that we're going to be the first to move to risk. We're going to be the first to take population management and make it real. Now, for those of you who are not familiar with our hospital system or New York City or Manhattan, within 3 miles, there are 3 honor roll hospitals: New York Presbyterian, NYU, and Mount Sinai. That's 3 top 15 hospitals of the 5,000 that U.S. News rates. And there's the brand in orthopedic special surgery, and there's the brand in cancer, MSK. 5 hospitals, 3 miles of each other. What do? Compete, kill each other. It's bad. It's bad. But of all those hospitals, who has the biggest Medicaid population? The Mount Sinai Health System, which is the biggest challenge to us. So when we say we're going to move away from fee-for-service medicine, I have a bunch of doctors who think, gee, I can move to MSK. I can move to special surgery. Who do I need these nut jobs telling me that now I have to be careful about how long the rehab is? And they go on. You can imagine how difficult it is in an environment like that. So we're taking a huge risk. But we're seeing things that our competitors haven't, and we think that we can succeed because New York State is one of the most inefficient states, one of the most expensive states that delivers health care. So we know that there's a place to add efficiency. We know that if we coordinate care, we can do better. We know that we can maintain our values if we do those investments. But imagine sitting before the kind of board of trustees that I have. Think of names like Kravis, Icahn, Hess. Okay? These are serious, successful people. And my telling them, so guys, we just made a $100 million investment in population management. Oh, really? You think it's going to pay off, they say? They all get their care's fee for service. They don't understand what I'm trying to do. But we take a tremendous risk. I think it's going to pay off, but that's what worries me. That's what's innovative about our healthcare system. I wish I was in Pittsburgh and I was, the dominant healthcare system. I didn't have all those competitors. And, and if I was a for-profit system, it'd be easy.
Wait. Well, we do what we do and pay taxes, just for the record. But I'd also note
what percent's your Medicaid?
Well, I'm so glad you asked, because in the aggregate, we are actually, and this is why this research is so important, is that we're the largest provider of uncompensated care across the country in the aggregate. We're the largest provider of Medicaid in the aggregate in the country, the largest provider of Medicare in the country in the aggregate.
That's because you've got a lot of hospitals, but as a percent of your business, what is it?
So this is
And
where...
is uncompensated care based on, how do you define it?
This is also where I'm...
I mean, as sticker price, or what's the...
Oh, no, patients who don't have insurance and for whom we write off entirely the coverage. No, but this is really why I'm also so excited about the work I told you about, for example, MRSA. So the Kaiser folks did a study on our data on the reducing MRSA. And while I just showed you that we could reduce infections by 44%, every time you have an infection, that's an avoidable cost. It's catastrophically avoidable harm for the patient. But for every 1,000 patients who had the winning strategy, not the hospital, but the health system writ large, your employers, the government, your tax dollars, save $171,000. And so this adds up very, very quickly. When you look at the inefficiencies of inferior quality or breaches of safety, it's a production failure, not to be callous about it. Results in catastrophic harm, but there's a tremendous amount of opportunity there. In contrast, I'm an optimist. Someone told me, you can't have a history of running the VA and not be an optimist. But I do think there's a lot of opportunity when we reach into the collective memory and when we think about different models. The privilege of working with the American Hospital Association, we started with a number of community conversations. And I recently was appointed to the Medicare Payment Advisory Commission. Those same numbers scare the heck out of me. Medicare is insolvent by 2026, give or take a year or two. And the question is, how do we create sustainability in healthcare? And we're going to have to do things differently. So I had the opportunity to really get this graduate course in ingesting data about what drives cost. And let's break it down as to what really drives cost. First, our society is not healthy. We have got to address the social determinants. You've heard the statement that zip code is more determinative than genetic code. And certainly populations that we all treat are in adverse zip codes. And those individuals are really difficult in terms of being able to provide service that is, by and large, geared to individuals with the social resources for continuity, the ability to make follow-up appointments, to have their prescriptions filled. So those are the breaches that we fill. But if we have 5% driving 50% of the cost, the question is, how do you keep the majority of the population from becoming that 5%? We have a large footprint in Texas. Did you know 2 out of 3 of the Hispanic males are going to have type 2 diabetes in their lifetime? Did you know? This is the first generation in recorded history that is going to experience shorter longevity than their parents because of the burden of diabetes and all of the complications. And all of these things are driving cost. Then if you break down what are the components of cost, actually one is a good, bad story. Depending on the economist you rate, between 40 and 65% of the cost drivers are new technologies. Some of these things are life-saving, but we have to address how to get technologies democratized so that others can get to them and how we have competition so we can drive the prices down. About 14 to 15% is pharmaceuticals, and pharmaceutical inflation writ large has gone from 11% of the health dollar to 14%.
You talk about things you're doing, not just the statistics of cost, but sort of some of the things that you're doing to address these things.
I wanted to pick up on what you were talking about in New York because, I think that's very courageous to jump in because I think a lot of systems, it's very different to go at risk than it is when you're doing a fee-for-service model.
Does everyone understand what at risk is?
So what at risk means is that, so for in our, somebody, a payer, like a government, like Medicare, gives you a capitation. They say, here's all the money you're going to get for these X number of people you're going to take care of, and you're going to need to figure out how to do all the things they need and get the kind of outcomes you want within that $1 you're getting. And so if you're a health plan, like we run health plans, we have $8 billion in full risk capitation. If we spend, $8 billion in $1, we lose money. And so we have to do that work. In a Sinai situation, it's with companies, but with different companies, right?
It used to be that you go to the doctor and the insurer paid $10 for doing this. Now they're paying, I'm making really simple numbers, $100 for taking care of you for a year. And the difference when we did this in the 90s with HMOs, and all of you we all hated it, right? It was only cost. Now there's measures of cost and quality. We can talk about how many thousands of quality measures and how they compete with each other, and you can't figure out which one and how hospitals game them. But the idea is that you're moving toward the value or the quality of the care rather than the quantity. Right. But they have to then be at risk for some of that money. If they spend more, they lose it. If they spend less, they keep it, but they also have to, at least in theory, they're supposed to be providing quality care in a measurable metrics way.
That's right. And one of the things that I think is really important, and there aren't that many experiments in the country yet to determine whether or not this is really going to work. But we have been fortunate in Pittsburgh to have been doing this experiment for quite a long time. And we just published an article this week in the Catalyst, New England, that gave the results in our market for affordability. And if you look at the top MSAs, the largest metropolitan areas in the country, we're the 26th least expensive for a family of four to buy insurance, for commercial insurance. And we're amongst the least expensive for Medicare as well. And the reason for that, we believe, is our ability to have created a lot of infrastructure and methodology to really try to reduce those costs and give people a high-quality outcome for a lower price point. Because we all talk about access. How do we get people the right care that they need? How do we get, people to be able to be seen quickly, et cetera? If you have a copay you can't afford, or you have a high deductible plan you can't afford, you don't have access to health care, even if you have insurance, right? You just don't have access. And so we have to figure out ways that we can make it affordable so people aren't choosing between paying their rent, buying milk for their kids, and going to the doctor. It's not a great set of choices.
So what are some of the things that you've had to do differently as you've...
think about this. All the time. How do we keep people out of the hospital? How do we keep people well? How do we keep people out of the emergency room? And when you have contracts which they're paying you a finite amount of money to take care of a population, it's suddenly in your interest to keep people well, not every time they get sick to say, let's go in the hospital. So how do we do that? Well, we do that with, I'm going to tell you a very interesting story of how we do that. A few years ago, Center for Medicare and Medicaid Innovation put out a proposal to decrease readmissions and to decrease unnecessary use of the emergency room. And about 3 years into our grant, I get a call from the people who are running the program in Washington, and they say, we want to come and site visit you. Now, this is in the middle of a grant period. Before I was the CEO, what I really did in my life was science. I was a brain researcher. That's all I did. I had a lot of grants. When they would come and they'd say they're going to visit you in the middle of a grant, you go, oh my God, this can only be bad news. They're not coming here to tell me good things, right? So we get the whole group together, and the Washington people say, and we're going to bring some consultants with us too. Oh boy, this is really going to get ugly. We sit down, and in the first 5 minutes they say, the reason we came here is because your results are so much better than everybody else's. And I say, well, what's that? And they say, well, you've decreased your readmissions by 49% and your unnecessary emergency room visits by 47%. We want to know how you did it. And we then begin to describe that we have a bunch of care coordinators who just graduated from college, who we trained on social issues, on the issues that were really keeping people ill, what you talked about. And they said, you know what's very interesting? All these other grants that we gave out, by and large, their program was that they assumed patients didn't understand the severity of their illness and they needed to be educated. I said, you didn't take that model. I said, we knew they knew what their disease was. Their problems were that the air in their NYCHA housing, their public housing, they hadn't had a filter changed in like a decade. And they have chronic obstructive pulmonary disease and asthma. Or they couldn't really have the time to cook a meal, and they were buying all these processed prepared foods. They didn't realize how much calories there was in it, how much sugar there was in it. And I can go on and on with the sociological issues that drive healthcare, the zip codes, more importantly, outcome than anything else. So we trained our people to do things like walk into the house, look at the air filter, talk to them about why were you unable to make your visit for your primary care appointment. Why, 50% of them, for time, their visits are being canceled. Why? And you'd hear things like, well, I'm employed off the books. My employer thinks I'm really just trying to goof off and not really have a hospital appointment. So we would intervene and say, no, they have a real appointment here. Or I couldn't take the time in public transit. It takes too long. And we'd have to figure out how to get people to the hospital or to the clinics. So these are all sociological issues. And it speaks to where we're making investments.
The most powerful prescription I ever wrote was for a window air conditioner, just to that point. It's not on any formulary that you've heard of except in VA. Kept a patient with emphysema, COPD as we call it today. He used to come in the hospital every 2 weeks. He'd come in about twice a year after that prescription. The work I told you about with the early elective delivery became part of Center for Medicare and Medicaid Innovation, Strong Start for Healthy Moms and Newborns. And it's estimated to have saved now billions of dollars. It wasn't a good economic decision for HCA. It reduced our NICU census, our newborn intensive care units, by about 40%. But it was the right thing to do. And so the work that Diane's doing, I think, is so interesting because you have to change the insurance models to reward the good behaviors, not provide perverse incentives for other things. I'm still optimistic about the data science. For example, using natural language processing and artificial intelligence for patients with new diagnosis of cancer. We have a computer that scans what used to take humans literally hundreds of thousands of hours, a 2,260% improvement in efficiency this past year, and redefining the work of cancer navigators. Used to spend 80% of their time reading path reports, pathology reports, to see if a patient had cancer, reassure them if they didn't, or get them care if they did, to now spending 80% of their time helping patients.
Let's take some audience questions. Is there a mic in the room? If not, just talk loud. Right here. Yeah. And we do have a mic. It's coming. And no speeches, please. I am way tougher than I look. I always tell people I've raised teenage boys. I will cut you off. Right.
Good morning. I run an at-risk healthcare model, so I fully believe in it. You had to explain what at-risk meant to this pretty advanced group of people. How do we both shift to risk-based fee structures and do what was talked about yesterday, create communication with the ultimate consumer that they can understand and make good decisions about?
I think that one of the things that is it needs to happen is we need to figure out a way that you can align some of the methodologies, because I think provider systems that are taking risk have a lot of different measures and metrics they have to do for everybody. So there's no one standard. I think we have to move to something that's a little more standardized, and they contradict,
diabetes
more
level
standardized. But I think the other challenge, we are doing a lot with big data as well. We're looking at, we've done between UPMC and Carnegie Mellon and Pitt, we're doing a lot of data work with deep data mining, et cetera. But I think as much as I believe that is really going to be our future, and it's going to help us a lot to get to these specific issues we have to get to with people, people's human behavior drive about 75% of the chronic diseases and costs in healthcare, right? And we know that if you change 3 risk factors, what we eat, that we don't smoke, and how we move, those 3 risk factors alone would reduce diabetes by 80% and cancer by 40%. But behavior change is incredibly hard, and it is heavily influenced by all those factors that we were talking about that you're working on with your community workers, helping people get over those barriers. So from my world, I mean, I think we have to look, there's no silver bullet on this stuff, right? You're gonna have to figure out what's the best cutting edge in science. You're gonna have to figure out how data supports and helps you. But we come back to the end of the day to human beings who have lots of complexity in their worlds. And how do we help and support them with a more holistic view of health? And I think that's the future that we have to get to somehow.
I would add, we have to improve access. People can't wait weeks for appointments. We have 24-hour access. We have to use the lower licensed people who are effective and just as effective as what we're doing. And then we have to change the compensation model, particularly for the primary care physicians. If a lot of their salary isn't at risk to keep people well, instead of just to churn people, we're never going to be effective in risk. And we've done that, and a lot of doctors are not ready for it, particularly the older generation. The younger people coming out of our medical school, they love what they're doing. They think it's going to be great. They understand the model is to keep people well. A lot of the older people say things like, oh, it used to be autonomous, my practice, I could live in a private, and now, I don't know, I'm going to have to sell. I'm going to have to be taken over because I just can't afford these insurance companies and all the administrative costs and on and on. And then you talk about risk, and they say, well, I don't want to do that. So it's this generational change.
I think we have to change the conversation. If I could get one single question, it would be, how do we have the greatest health for our society, the best care for the individual, access for the most people at the lowest cost? And in working with the American Hospital Associations, who works with 5,500 member hospitals and health systems, they're not all in the same place. The financial status of those entities varies from solvent to quite insolvent. And so I think we need two paths. We need to be able to both define the future as well as define a trajectory toward getting there. Let me give you a concrete example of how this works. When I was in VA and we increased access to preventive services, when veterans came to diagnosis colon cancer in the late 90s, it was almost invariably through the wall of the colon or metastatic. By 2004, it was almost always a polyp or just into the wall. Why was that? Access was covered for screening colonoscopy, essentially a curable preventable cancer. When we cut out preventive services, we're making a poor investment in the long term. And if I could reframe one thing in Congress, it would be not scoring preventive services on a one-year return. You're not going to get it. You need a decade to get that return.
Next question, right over here. Yeah, fine. Mike.
I can talk loud. Richard Gibbs, Baylor College.
They need it for the recording, I think.
Thank you. Richard Gibbs, Baylor College of Medicine in Houston. My question is simple. Do you think genetic testing is going to save you money? And if so, why? If not,
Let's
why
have a
not?
really quick question on that because it's not like a health system in the same way as it.
I think it's clearly the future. In cancer, it's critical. You can get the right treatment for the right patient, and it'll be most effective.
And it's going to be critical we know the answers to these things because some of the new medications are $450,000 for one treatment episode.
Yeah.
And so if you give that to the wrong person, it's a bad mistake for a lot of reasons.
Right, so knowing which drug.
Exactly.
But how much are health plans covering it so far? It's changing, but not where it
Minimally.
needs to be?
Minimally.
Well,
When you have your own health plan.
The new CAR-T drug that just came out, it is pricing at that range, and we're covering it because it cures leukemia.
Right.
But you asked about genetic testing, and that's
testing.
minimal.
No, genetic testing, that's a different question.
That's being.
Some yes, some no.
Okay. Right here.
I'm Kurt Malkoff. I'm a PhD clinical psychologist that provides employee-based services to hospitals, institutions, what have you. Speak, Ken, a little bit about the care coordinator position. It's $100 million against $8 billion. It's a rounding error, but it seems to be getting traction in terms of cost control and the issues that Diane spoke to, the smoking, the eating, what have you.
It's also being paid for.
Well, it's not being paid for.
Some of it is now. There's some.
Right, it's a cost, and you make up for it by keeping people well. What we do is there are a lot of college graduates who, between graduate school and undergraduate, really want a job in healthcare. And we find bright kids with the right personalities, give them 2 months of training around what are the social issues, have them mentored, go out and then give them a caseload. And they're great at it. if you pick the right personalities, you get extroverted people who, are really not afraid to ask the right questions, and they know what to ask. They can have a real influence.
Longevity of that position.
These kids go on to better things after a few years, so we're always replacing them and turning them over.
Question over here.
Thank you. I'm Muhammad Sabir from Pakistan. So I come from a community of nomadic and gypsies. So we have nomads and gypsies. So we live in most of my community, ultimate state of homelessness. So I want to ask, especially to Kenneth, how can we design a system, or how can a system who serves this particular set of population who are wandering and who have nomadic lifestyle, or how it can, like the traditional and conventional health system, can serve it, because these people are mostly very prone to health hazards in their lifestyle, and they are not in in the conversation most of time, because these conversation mostly people who live in houses, and the people who live in curb and so. Can you put some light on it? Thank you.
Well, my people in global health would probably say the most effective interventions there are to identify community leaders, train them in what to look out for, and get them to get the communities to trust the healthcare system. But you need embedded kind of case managers who are community leaders who want to do this on a voluntary basis and really know everybody in their little community and can identify what are healthy behaviors and tell people what are healthy behaviors, or can identify people as they're becoming ill and get them to the right places. But we've got to embed essentially caseworkers.
Over here. And let's do quick. We have 5 minutes, so let's get as many as we can in.
I'm Sally McNagney. I'm a primary care internist in the partner system in Boston. And I would love your advice, or really everyone's advice, on how we can create a national electronic medical record that, just to give you a sense, I'm sort of a doctor's doctor. I get all the parents of the doctors in the Boston area, and they're all returning from Florida. And to be honest, I get faxes or mailed records, and I get a lot of patients who might be leaving another system in Boston, which is less than a mile away from me, Beth Israel, and I'm incapable of seeing any medical information from a healthcare system about a mile away or across the country. I love the VA system, but I'm really sick of not being able to have any access to healthcare records outside of partners.
My
think
desk is
there's
right
a
near the
problem,
scan
yeah.
machine, and every once in a while somebody comes up and says, "How do you fax?" And I said, "Oh, doctor's appointment? Oh, it's the only time anyone."
Exactly.
None of us know how to use a fax anymore.
right.
And I happen to sit there, and I can tell who's sick. And if I keep it, I'm not covered by HIPAA, but I
Right.
just keep it quiet.
But I think it would be, if we were talking about the highway system in the United States, and there was never any national program for it, and states weren't involved in an integrated program between the state and the federal government, and the local environment wasn't actually improving in their own way what needed to happen, we would have the same mess with our highway systems that we have in healthcare. And I think that until we have the coordination between federal, state, and local entities, that we agree on standardization, interoperability, and all the other things, because it's not just the electronics that have to work right, it's the data that has to work right, and it's both the infrastructure and the supporting structures that have to happen. So I think that's where it has to head, and that means there's funding needed.
So Ken, in your situation, when you have so many great hospitals, and you've got somebody who had their hip done at special surgery, and they've got their endocrinologist at NYU, and they've got their cardiologist at Sinai, and whatever other disease is, at Presbyterian,
Right.
how much interoperability is there now in New York City?
If they're not all on the Epic system, it's very difficult.
But Ken, has it?
But no, they're software that we've built so that some EMRs talk to other EMRs. They do that within our hospital system, but from outside the hospital system, it's much more difficult. We really need, I think, national legislation on this. And the impetus for that should be for us to remember that there were great subsidies from the government that established so much of the EMR now. The public has a right to be able to have these systems interoperable,
And
because
there's
we
all-
paid for a
gag-
larger
yeah,
part of
There's
it.
gag rules and all sorts of business reasons that you don't.
There
right?
is a positive note, which is that the Center for Medical Interoperability is a new entity that brings together a lot of frustrated providers. I mean, the major providers, your organizations may be on it, but you know, it actually operates under the rules of DARPA, so it escapes from the antitrust, and it's saying these need to be the standards so we can have the end-to-end interoperability, because your system shouldn't have to build a system to talk to another system next door.
And I should be able to do my work without having to get up and show people how to use the fax machine.
Absolutely.
I have one more question right over here. I think then we need to end it.
Hi, Jeffrey Williams from Myrtle Beach. I'm a private practicing anesthesiologist. My question is, I agree with everything we're saying about hospitals, and I certainly work in a hospital, but have we ever asked the consumer how they want healthcare delivered? Have we ever taken the time to sit down with somebody in their teens, 20s, 30s, and what they're expecting and how they want it delivered?
We've done some interesting work. We invited a whole bunch of our health plan members to dinner, and we do this periodically, and we just say, come and tell us what's wrong with our healthcare system. And we only invite them if they're on 10 or more medications and have seen 6 or more doctors in the last 6 months. And then we say, come in, and none of them have cancer because we were trying to get the chronic, complex people, right? And they will tell you very simply, it's a maze. What we need is a navigator. We need somebody to help us to get from point to point. And I think what they also need is some really common sense, basic information provided to them, but then the support to actually make whatever that is happen. And I think that's been a huge missing component, which is what I love to hear about what your program is with the kids coming out of
And
school.
also with hospital at home.
That's
We
another
didn't
good-
know how much patients would enjoy hospital at home, whether they would be frightened of hospital at home, because they would say, gee, if I really get sick, you're going to be able to take care of me? What if I have an emergency now? And it's exact opposite. The patient satisfaction scores are through the roof. Our issue now is scaling it.
Yeah, it's a
But
really
kids
successful
want
high
some other
system,
stuff. Younger people, if you look
They
at
just
younger
want
people,
zap-zap.
yeah, like get me now, let me have this, and do it on my phone, if I could.
Right.
All right,
So
we're out
that's
of
okay
time.
too.
Totally out of time. You can talk to them if they have time.